Malcolm,
Hold on, everybody.
can you hear me?
Yes.
Okay? Perfect.
Good morning, everybody. Welcome. You're attending our first webinar for 2025, presented by CHLP's Aging Advisory Council, entitled Where Are We Now? For the next 2 years, our project, From the Margins to the Center, examining the legal needs of especially marginalized people living and aging with HIV, will work to achieve 5 core objectives: enhancing analysis and knowledge of the legal needs of especially marginalized people aging with HIV, continuing to foster a core group of advocates with subject matter expertise on the legal needs of people living and aging with HIV, drill down into the specific issues, impacts of criminalization on the lives of people living and aging with HIV, drill down into the specific issues faced by transgender people living and aging with HIV, and build policy solutions and achievable advocacy goals to address the legal needs of especially marginalized people living and aging with HIV. I am Malcolm Reed, the CEO of Unity Arc Advocacy Group, LLC, and the aging consultant for the Center of HIV Law and Policy. In today's webinar, we will reflect on the past, present, and future of aging with HIV, discuss reentry and socialization challenges of those previously incarcerated, examine policy, healthcare, and community support needs, and we hope overall to inspire action and intergenerational advocacy. We have a fantastic group of panelists, all representing the Aging Advisory Council: Achim Howard, Kerry Thomas, Kim Kennedy, and Tez Anderson. I'll let them introduce themselves as we go to the first topic of conversation. I also want to mention that 2 of our council members, Davina Otola and Shakina Rose, you know Davina as Positively D, and Shakina Rose, I might say the award-winning Shakina Rose, who was just presented with a Persistent Advocate Award at the recent AIDS Watch from the USPL HIV Caucus. Neither of those wonderful people could be here today, but they are with us in our hearts and spiritually. All right, so let's get to the first topic. Where we've been, the history and the lessons. So, panelists, good afternoon. Introduce yourself and then tell us, what do you believe are the biggest challenges facing people aging with HIV today? Action, I'll start with you. You're muted. Action, take yourself off mute.
Oh, I'm sorry. Thought it was off mute.
There you
Am I
go.
on
You good.
mute now?
You good. You good now.
Okay. My name is Achim Howard. I am an advocate as well as I stand on the board of the advisory board of Positively Trans. Um, can you repeat the question one more time, sir?
What do you believe are the biggest challenges facing people aging with HIV today?
I believe the biggest challenge in facing HIV, people living with HIV today, is stigma and the lack of education around it, or um, people don't want to grasp that you can live well with HIV. Um, Especially living in the South, there is still a lack of education or the want to learn about HIV. Um, and I also believe that the laws here in certain areas in the South um, would is a challenge as well, especially for transgender individuals.
Okay, and let me ask you, Action, what state are you in?
I'm in New Orleans, Louisiana, sir.
Okay, thank you. So I'll come back to, as we talk about laws and criminalization, I'll come back to you. Um, Carrie, same question. What do you believe are the biggest challenges facing people aging with HIV today?
Yeah, good to see you again, Malcolm, and all the panelists and everyone who's coming in today. I'm Kerry Thomas. I'm the policy strategist, a decriminalization strategist with Zero Project. And yeah, this is a topic that as we get further in the conversation, is very dear to my heart. And I like what HM is talking about when he had the foundation of stigma. To me, that's kind of the umbrella, if you will. That's the overarching, but that leads into many other areas, which we'll probably get into a lot today, Malcolm. But primarily, it comes to my mind when I think about the biggest issues that go along with stigma is just access to resources and just navigating the system. That's with all the changes that come time happen daily, hourly, by the month, just knowing where to go to ask for help. So if I'm living under if I'm living with HIV, I'm aging, I'm formerly incarcerated. All those things are almost not. I don't like to call them three strikes, but the three challenges that we have to manage the system just to live my life as well as I possibly can. And I think what we hear across the board and all our surveys that we've worked with is that seems to resonate with folks. It's like where am I going to get the help at? It's never about whether or not a lack of willingness to be self-supportive, but what's the roadmap to get the support that I can need, that I can live the quality of life that I want to get to. Yeah, again, thanks, Malcolm.
Excellent. Thank you, Carrie. Kim, same question. Introduce yourself and what do you believe are the biggest challenges facing people aging with HIV? I think you're muted as well. I can't hear you. It doesn't show you're on mute, but it looks, I can't hear you. I think I got you now. Go ahead. Nope. Whatever you did a second ago. There you go, right there.
You can
Say
hear me?
something. Yeah, now I can hear you.
Okay. Ooh, so I'm in trouble. Hi, good afternoon, everyone. My name is Kim Kennedy, and I think is the biggest challenges. You said with people who are aging,
People
with people.
aging with HIV, yes.
Well, I think it's a complex question because I think that every generation, everybody who is aging, has different problems, different challenges, especially geographically. Like a situation that I might have in New York might mirror something. It might look different from somebody in California, or just like somebody in New Orleans. I think that the lack of resources, I think the lack of knowledge, also for my demographic, those who are born positive. Um, our biggest challenge is people recognizing that even though we might be younger than those over 50, that we have the same challenges, if not some little bit more complex, because we're in our 20s and in our 30s. So that is just a mismark, at least in my demographic.
Thank you for that. For the people born positive, that whole demographic faces different challenges. Well, the same challenges at an early age, or sometimes different challenges, especially with stigma and with access to healthcare. So, Tez, finally, as the last panelist, same question to you.
Hi, everybody. I'm Tez Anderson. I live in San Francisco. I'm the founder of Let's Kick Ass AIDS Survivor Syndrome and the sponsor of the HIV Long-Term Survivor Awareness Day coming up on June 5th. And just so you know, that this year's theme is Leading with Legacy, which is what we're talking about today. What is our legacy? The biggest issue, well, for me, is poverty. I mean, a lot of it has to do with lack of money, and because I never expected to be 66, which I will be on Friday. So I don't have a 401k or anything set aside. So I think a lot of it's financial stuff we overlook often. It's also the lack of socialization. I mean, we run out of people to talk to, and the older we get, the harder it is to make new friends. So we retreat to isolation, which I don't think is helpful to any of us. I mean, we know that, they say loneliness kills people as much as cigarette smoking does. So that's the general two, I think, is those. I mean, stigma, yes. My personal opinion about stigma is that if I don't take it on, it can't hurt me. But I do know that's not really completely true. But in my life, I've been so open about being HIV positive that I haven't suffered some of the discrimination, and I'm also white. So, I mean, let's just call a spade a spade. I'm not, the prime suspect for that. And folks really have to worry about the ethnicity aspect of it as well. So I say that as a privileged white man.
Thank you, Tez. I really appreciate you bringing that into the space. The privilege of race, the privilege of being a white cisgender man living with HIV and being open and out about your sexuality and about your HIV status looks a lot different from an Action, who is a man of trans experience, Black, living in the South. So, and I do want to point out that Action is in Louisiana. Carrie, you're in what state? I'm sorry, I forgot. Idaho or Iowa?
Yeah, I forgot to mention that as well. I'm in Boise, Idaho.
You're in Idaho. Kim is in New York, and Tez is in California. So we have a nice mix of red and blue states. So let's move to the next question in this section. Kim, what lessons can we take from the past to navigate today's political landscape? And I'm really speaking from what's happening politically today.
So I know that, so I'm just gonna put it out there. I'm 38, right? So I know that for me, most people look at my age and say, like, what would you know about what was going on back then? And I'm talking about when HIV first started, like when it was really prevalent in the early 90s. I remember I think more so for me because my grandmother would always have the news on and she would always talk about it. And because I started my advocacy at the age of 12, I had elders who would show me, connect me with like AIDS Institute, Black AIDS Institute, teaching me about AIDS Alliance, telling me about, teaching me what my rights are as a Black woman. And at that time, it was a Black young woman, like a Black little girl, and what that looks like. We have those spaces, but those spaces aren't the way how it used to be at that time. I think that right now you have to know the right people to be put in those spaces to learn those laws, to learn what's going on in your state, to know how to advocate for yourself, to know when I'm 15 and I was going to Albany, what to say and get ready for what the people are about to say. So that way I can counter off on whatever the next thing I'm going to go and to vouch for it. Those are a lot of the things that we don't have in place right now where we can mobilize or even just learn from the past lessons that other people was doing. We're not having those conversations. Before it was such a state of crisis that everybody was talking, everybody was sharing. Right now it seems kind of siloed where, again, knowing the right person, being in the right space, really having and I don't want to say elders, but the elders really tell us like what worked and what didn't work, so we can use that from whatever happened in the late 80s, the early 90s to implement that now. I think that's the piece that we're missing to at least navigate this political climate right now.
Yeah, thank you for that. I think you bring up a good point. That community advocacy, that spirit that we're all here together and we all need to fight this, is missing, and I hear that. I feel that. Unfortunately or fortunately, we may be getting back there faster than we think due to what's going on today. Tez, what about you? What lessons can we take from the past to navigate today's political landscape?
Well, I think first of all, the lesson from the past is that when we first started to speak up about this, it took 2 years for anything at all to happen. But the more we spoke out as a community, as one body to people, things started to change for us. And given what's going on in the political climate right now, I have no idea. I find myself very confused about how to move forward because we don't know what's coming around the bend with this crazy ass president of ours. Every day is a new roller coaster, and so I think the best thing we can do is to set strategies for as many of us as possible, because we have a way of kind of subdividing in these groups and getting our needs met individually, which is great, but we have to look at the overall the larger group in this aspect, because I think right now going forward we're going to have a harder road to hoe, and maybe some of these things we want as individuals, as young people, as older people, we can't get because we don't know what we're facing. And I think we have budget cuts and Social Security budget cuts. I have sinuses today, so I apologize for my stammering. It's really bad in California today. Anyway, the fact is that we need to learn that when we spoke up, we stuck together and we got things done. Action was started. And I think the other thing is that well, we're in a different age. We have better medications now if we have access to them, and I think that we have to be fighting for access. I'm looking at Medicare and Medicaid cuts coming, and if we don't have our supplies, if we don't have our drugs, I can't afford them. I'm on Medicare. That's also being cut. So there's a lot of anxiety right now in my world around, for me personally, about how much we're under attack again. And my husband seems to be watching Gilead on a TV show about the same thing happening there. And it's really quite disturbing when they put their minds to it. So I hope we all have our access to our medications and to our health care moving forward. Thank you.
Okay, thank you. Carrie, what about you?
Yeah, I think both Tez and Kim kind of touched on a little bit, and just a little bit of a background. I'll be 61 this year, and I tested positive with HIV in 1988. So by my math, that's roughly 30, 36, 37 years. And I've also spent 15 of those years incarcerated. And I've been out now just over a year and a half. And so I wanted to frame that context because it's when we started the 15 years was the time that I would have been putting money in savings, that I would have had access to start even if I back up to 88, I didn't expect I would see 60. I mean, 60 was, most of us are in the same situation. We first got our diagnosis. They're saying maybe, at least what I heard them say was 2, maybe 3 years tops. So 37 years later, the time to switch my mind frame about for lifetime planning, that was a challenge. And then having that interrupted for 15 years of incarceration, that was the main earning years that I can put stuff away from when I get older. And so I think all that was the context of the anxiety. I think what Tez talked about, and Kim to some degree said the same thing of the uncertainty is what causes a lot of stress. I mean, how do we save? How do we put things in context? I love that Tez, I want to definitely touch on the poverty that, because we know the numbers are high, the people that are aging with HIV that are living in the poverty, in poverty right now. whether that's like food insecurity, housing insecurity, and not even to mention yet the talk about the need for the medication. That was one of the things that we really talked about last week. And great, don't get me wrong, at HROS, there was an incredible amount of advocacy and about work that was being done last week. And that was one of the things that we talked about. Is like, wait, just because that we're living longer, just because you take away the medication, you quit funding, the disease doesn't go away. It would be nice if we simply just said, okay, we're going to stop funding Ryan White, and you're not going to no longer get your medication. And then HIV just stopped, and I was able to go about my day. That would be nice, but that's not the case. And then it extends to where the funding is that we could potentially, we know for sure when it comes to treatment, the sooner you get folks on treatment, the better their life outcomes are going to be. And so if we get to the point where Ryan White, where we have to go back to we're having waiting list, we can't wait. The longer you wait to get your treatment, that, as we also know, is going to cause more harm to the people. And then if everyone wants to bring this to an end, if everyone wants to limit the amount of infections that go across, the last thing you want to do is to cut the treatment that we know is prevention, and that we know that people access can end this. And so I guess what I'm saying, the biggest threat right now is that the long range outcomes of the policy decisions that we're making today is my biggest concern.
Yeah, and I definitely hear that. So what I'm trying to get to is and I think Kim really got to it. So, in the 80s and 90s, when we had ACT UP and we had so many other organizations that came out and galvanized the community, if you will. Do you see any of that happening today? Is there anything that is going on that you're working on, the people that you're working with, that you see some positive light? I think you mentioned AIDS Watch. What are some of those things today that we learned from the past that you think will work today, if anything?
I was at my husband and I walked down to the Hands Off rally last week,
Mm-hmm.
and there was thousands of people crowded into our city hall area, and they were counting signs of all kinds, but none of them had to do with any specific issue, but just our democracy. And I feel like, tying our tails to that idea of what is democracy and how we have to fight for that right now, because it's really under attack. And what was funny was that they were doing chants that they had stolen from ACT UP. Hey ho ho ho, let's fight back. And they had something that was really lame, because they would just say fight back. They didn't say anything else before it. I was adding stuff to it.
Mm-hmm.
But ACT UP changed the face of the way we deal with these issues and how we confront the healthcare industry and how we confront the government. And so I heard the echoes of our past in the president down there, and yet they weren't talking about AIDS. They were talking about other issues, which are going to be affecting all of us,
Exactly. Okay. All right. Anybody else?
So I can speak on, so for those who are born positive, lifetime survivors, are also known as dandelions.
Mm-hmm.
We stormed the stage 2 years ago of USCHA and demanded, like, you will recognize that we are aging with HIV. You will recognize that we are still here. That was the start of a movement. That was the start of us coming together, building out a network, building out a directory for us, going into different places and not taking less than, you will have us at the table and you will include us in these decisions. So that's been the last 2 years where we have been mobilizing together, because we recognize that, yeah, we need everybody else to help us get to where we do, to get to where we need to get to when it comes to aging, when it comes to living. And just like every other group is, we are together because that's something that we didn't have, and we are a very small population, but we also are going to other populations as well and asking, like, hey, how can we mobilize with you? This is what we need. This is what do you need? So that way we can assist, so that way, God forbid, y'all pass away. We are young. But we still, like, we are the up and coming, and a lot of us are doing the work. We've been doing the work for a long time. And I know that right now it's hard to see like a lot of the work because all of us, we're still in like these stepping stones. We're still in the early stages or reconnecting, or I would say the revitalization of a lot of the things that we wasn't doing so much because we were relaxed. We were comfortable. Now it's like reignited where not just my group, but you can see the other groups coming together. Other groups are, we're like you said earlier, I think it was Carrie, how we're like all, we're trying to come together and do more. And I think that's what is something that was happening before, where people were coming together, people were talking. It's just, we just need to talk a little bit louder and just be more strategic. How everybody was strategic before, just really be in this strategy mode of how can we help each other out in this fight so that way we can all get what we need, or at least on the verge, at least towards it in some kind of way.
And Malcolm,
Excellent.
if I can add,
Go
if I
ahead.
can add just one thing on that, I think that Kim, it really sparked an interest in mine, and I wonder if we start to frame the discussion a tad bit differently, and when it comes to aging, because in my experience, aging is a verb. It's something that I'm doing. It's not a destination. And so when
Hmm.
we look at and for me, when I look under that context, then as soon as someone has a diagnosis, by definition, they are now aging with HIV.
Hmm.
And so to me, that's far more inclusive than saying when I get to be 65 or I get to be 55, whatever that mark is, that like it's a destination. When you get to that point, now you're aging. No, I've been aging since I was 24. Kim's been aging since day one. And so it brings us all together when we look under the same umbrella. Wait a second, we're all under this thing together. Because every one of us, despite if it was 88, 2008, and God forbid, whatever eight's coming down the road, 28, as soon as you get the diagnosis, you're in the club, so to speak. And so
Hmm.
we need to start acting as if we are in that club and pull our resources together, which Kim and Tez and HMR are talking about, and let's move together, not in our individual silos. They want us in silos enough as it is. That's they prefer that we stay in silos. And I'm like, daggone it, come on. I'm aging just like you are. Today's the 8th, and God willing, if I see the 9th, I just got another day older, aging with HIV. Come on, let's all get in together and fight and do the same fight.
So, from a policy perspective, I know one of the reasons why there is that separation of age, year 50 cutoff or year 65 cutoff, is simply because of the way um, um, support is structured. We talk about Medicaid, Medicare, and Ryan White and all of those other things that are there to support people living with HIV. So, in that scenario, Kerry, how do you see policy changing to support people who are aging with HIV, whether they be 1 years old or 65 years old?
I'm glad you brought that up. I mean, as far as policy, the approach that we have going into these discussions about what we need, because we are all we're well aware over the past, since this administration has been sworn in, that they want to start cutting back as much as they possibly can. And so, as one voice, policy wise, to make sure that we're really crystal clear on what it means to the Ryan White funding. When it gets to the state level, whether or not, and way in Idaho, which is Idaho claims to be a low incident state, and how that's being translated as, since we're a low incident state, we don't need the same amount of resources. Well, folks like Carrie Thomas still need the resources. I can't afford my medication. And so to have in one voice policy wise, and I know that there's documents, and Malcolm, you can speak this much better than I can, strictly outline what our asks are in order to have a set plan for people. You're right, Malcolm. As long as we stay that once you turn 55 or 65, then it kicks in. We know cost wise, that's the last thing we want to do. And so to be more specific with your answer, is it'll be more cost effective, as we know, if we start as early as possible. Therefore, when I'm 65, then I'm not saying, wait a second, I'm behind the ball with all the other complications that come along with living with HIV. It would be nice if it was simply one pill. But as we know, as we get older, especially with HIV, the heart failure starts to come in. the high blood pressure, cholesterol, all the comorbidities that come along with it, we can treat those early if we recognize that we're living with HIV from day one.
Excellent.
Thank you for the
Excellent.
question, Malcolm.
All right, and thank you all for the answer. I'm going to move on to the next section in this webinar, section 2, and we really want to talk about criminalization. So we know that there are people who have been criminalized due to their HIV status, people who were on their medication who could not transmit HIV because U equals U, undetectable equals untransmittable, who were in care, treatment is prevention. But for some reason, whether they did not disclose or whatever, they found themselves criminalized. So when we talk about criminalization, we know that there are several states that have laws that criminalize people living with HIV. And as I mentioned, in Louisiana right now, we know that they are trying to expand that criminalization. Right now, there is, from what I understand, and I don't have the bill number, but I understand there is a bill in the Louisiana State House that says that if you are diagnosed with an STD or you are diagnosed with HIV, they're going to put an ankle bracelet on you. So we know that. But when we talk about people who are criminalized who are older, and this is where the aging conversation changes a little bit, because we're talking about people who are, older adults living with HIV who are coming back into society after incarceration, reentry, and socialization. How do we reconnect, and what's our advice to reconnect them? Kerry, I know this is something that is really important to you. So again, just in case everybody didn't hear your story as you were introducing yourself, tell your story, and then let's talk about how can people recently released from incarceration rebuild their lives with dignity.
Again, thank you, Malcolm. And wow, where to start on this topic? So Idaho has one of the states that has a criminalization statute, 39608. I'll probably never forget that number. And I was criminalized, or I was convicted of not being able to prove that I disclosed my HIV status to my sexual partner at that time. And so my original sentence was 30 years, and and I think it's almost a roadmap on how to talk to folks, because after 15 years, the Idaho Commission on Pardon and Parole was willing to finally look at the medical facts of living with HIV. And they determined that I cannot transmit the virus. So therefore, they cut my sentence in half. And then I was able to get out. And so with the context of aging with HIV, now it's that, and incarceration, the roadblocks of starting over are incredible. And it's not just from talking from me, it's talking to other folks that are in similar situations. But to talk specifically about it's every area. When you're released on parole, I like to say now that I'm not necessarily released or that I am free. I'm simply under a different custody level. What I mean by that is that the most severe is close custody, where you get out a half hour, 45 minutes a day, all the way to work centers, to where you're able to work in the community, and now community supervision, which I'm under, which we call parole. And I want to make sure that the perception that once you're released on parole, there aren't any strings attached, that's not true. And everything that I do, there's still that supervision model with the scrape of trying to get my freedoms back to be able to make my own decision. With doing that also comes the fact that we need help from everything from housing, from food insecurity, because even if you live in the way that the most states work, is even if when you're living in a halfway house and you're paying your rent every month, that doesn't count toward your being able to pay rent. It shows that the house paid rent or paid the mortgage, but you don't get credit. So even if you want to move out on your own, you're limited because you don't have a history. After 15 years, in my case, 15 years, I don't have a history of being someone who regularly pays his rent. a lot of the states that are criminalization states for folks that are living with HIV and aging, there is the stipulation of, albeit on the sex offender registry, which as most of us already know, that limits what you can do as far as where you can live, where you can work, and how you can travel. So if the goal is to be to improve a person's quality of life, there's these roadblocks that are put there. And people say deliberately or not, I don't, that's a different conversation, but the roadblocks nonetheless. The optimist side of me says, I believe, to more speak to your question, Malcolm, I believe that it has to start on day one. And when we're talking about how the community comes together, when we know someone's currently incarcerated and live with HIV, whether it's under a criminalization statute or just someone live with HIV and getting ready to get out, that reentry process has to start on day one, meaning that we start to build the network of support. By the time that they are able to walk out, they already have the foundation in place. That's something I worked on for, again, I didn't think I was going to get out of 15 years. I thought I was going to get out 15 years from now at a much older age. And so while I was there, I was thinking, okay, if God will, I'm still alive, what am I going to need to be successful? Those are the conversations we have to have. First of all, we have to let folks that are incarcerated know there is a place to call. And then we start building a timetable to outline what it's going to look like that when you get out. Where are you going to live? Where are you going to get your food? Where are you going to get your medical care? Those are the three main things that lead to a better quality of life. We know they lead to a quality of life. We know they lead to more success for people re-entering the community, keeping them from going back. Where am I going to live? What am I going to eat? And where am I going to work? And then so if we can start building a network of folks and able to have those resources at a state level, then that'll go a long way to helping folks be more successful once they're released. I kind of rambled a little bit, Malcolm, so I hope I answered your question.
No, you definitely did. I'm gonna come back to you in a second, but I want to get Action in here for a second. Action, same question for you. Kerry has expanded on his experience of being incarcerated and re-entering society. I know that you know and work with some folks of trans experience who have been incarcerated and are trying to get back in society. What does that process look like for them? I think you're on mute.
Am I off mute?
You're off mute.
Okay. It's mainly people need support. They need help with rebuilding their life after incarceration. Housing, food, jobs. We need more programs that will help trans people with people living trans experience. Because without that, we still gonna have the revolving door effect. They need support. We need more trans-led organizations that will help people to re-enter society. Basically, he explained the same thing that he needed in order to get out is the same thing that trans people need. And people need to realize that trans people are human. So the same things that, the cisgender individuals will need is the same thing that the transgender population will need as well. We need jobs. There are people hiding right now because the political climate, they're scared. Basically, that's all. The same thing that he stressed on, I emphasize. We need the same.
Excellent. All right. Well, thank you very much to both of you on that question. Kerry, before I go to the next question, I'm going to come back to the support for and the advocacy for some of the things that you would like to see and that Action mentioned as well. So we know that, and I'm going to give you a chance to mention the organization that you work for, and we know that they work for, as well as CHLP works for improving the rights and getting rid of HIV criminalization. What other advocacy would you like to see as far as reentry into society? How can we as advocates support you, support people of trans experience who are reentering into society?
Yeah, excellent question, Malcolm, and thank you for posing that. And I want to touch on what HM is talking about as far as the individuals, and I'm just, since we're talking about criminalization, let's specifically talk about, just for a quick moment, to answer your question, Malcolm, the folks who have trans experience that are currently incarcerated going to be released. First of all, the criminal justice system for folks with trans experience is atrocious, at every level, and at every, the worst you can possibly think it can be, it's probably 10 times worse than that. Let's get that out there, which really makes that challenges even more so, even when they go to the house, when they're released and they go to a halfway house. Some cities, some states call it a halfway house. Some people call it just a transitional housing, whatever. There isn't, to the best of my knowledge, houses specifically for the trans community. What does that mean? The same abuse that they're having while they're incarcerated, when they go to a halfway house, sometimes it's even worse, because now there's no supervision there. There's limited supervision. There's someone to call when you're being assaulted inside the correctional facility. When folks are going out to halfway houses, there's none of that. And so that leads to fear, that leads to not wanting to be there, leads to frustration, leads to all the mental things that come along with that. And you're supposed to be living free. So to answer your question, again, we work with Zero Project, and that's one of the things that we've really fleshed out at Zero Project, is that there are a lot of folks across the country that are doing some heavy lifting to get these laws changed. Some incredible work, hours and hours, dedicated people that are trying to get the statutes changed. We've made some progress. That's the long term in some cases. What about the day to day? How are folks swinging their feet out of bed and standing up to go just do the basic things today? That's where the advocacy, I believe, is falling short. And that we really need to focus on advocating for resources available. And again, I'll say that there's not. I would argue, I don't have the stats, the numbers behind this, but I argue that none of these folks are looking for a handout. That's not the case. What we are looking for is just the pathway to order to make my own decisions. Incarceration, it takes away all your decision making. Freedom means that I have the ability to make my own decisions, and I'm given the opportunities to do that. That's what we're looking for. And so I guess what I would push for, Malcolm, is that we have an opportunity to start to work together from a state by state basis, coalition building, if you will, and that we know when so-and-so is getting released, prior to the release, we have things in place that they can have secure housing. And the secure housing is not temporary housing, that they have a place to go. Then they have quality medical care to go with that. Even if that's it's almost like a program where you can review it after 6 months or to a year, but give it time to see flesh out what's working before we say that you're good enough. Good luck to you. Hope you don't fall and end up coming back. Nobody wants to come back. That is not a thing. The idea that the recidivism rate is not because people are raising their hand to go back, is because they're limited with their options, and it starts to steamroll from one situation to the next. Where going back is, I've talked to someone just recently. Their level of frustration was so great. They were saying, I can't afford medical care. At least in the prison environment, they have to treat me. That has to change.
Yeah, I get it. I've heard for years many people who were released from incarceration said, my life was better while I was inside. So I definitely understand that and understand where you're going from. And to Action's point, as a man of trans experience, the feeling is, hey, we just want to be treated like people. But you bring up some good points. There is no place that is accepting to a person of trans experience when they are released from incarceration. And that's some of the advocacy that we can work on. When I first started working on this project, one of the things that I said was I wanted to find the advocacy and advocate for people in between the long term. What does the short term advocacy look like? We're trying to change laws. We're trying to make things better long term from a policy perspective. And what does that look like in the short term? How do we make life better for people who are going through the experience? And so I think you've given us some good pointers. You and Action both, making sure that, housing, food, and jobs, like you said, housing, food, job. If I have those, I'm not going to go out there on the street and do something, that's going to put me back in the system. So we have to continue to fight for those things. And we know that now our fight is even bigger, right? Our fight is real, because from an HIV position, as well as from a trans position, the fight just got a whole lot bigger, especially for people of trans experience, who they're trying to erase. So those are some of our marching orders, and we will definitely take those back. So let's move on. And this question is for both of you. What are the biggest gaps in long-term care and support services? So as a person living with HIV, what are you most concerned about as you age to see what your long-term care and support is going to be? Either you can jump in first.
Long-term care, as in health care, how you provide for aging, issues around aging. That's a big, scary topic. I live in a third floor walk-up, and the older I get, sometimes it's difficult to walk up those 3 flights of stairs. I think we haven't ever addressed this as a group, because I think for so many of us, it wasn't even possible. As Carrie said earlier, we were going to live to be this age. And so it was one of the things we all overlooked because we didn't think we would need it. And so being the pioneers that we are, we have to hoe that row ourselves. Row that hoe. What's that? Hoe the row. Ourselves. We have to invent it, and it's going to be difficult because we don't. I live in San Francisco, where housing shortages are, well known, and costs are very expensive. Excuse me, anyway, sorry about that. My frog.
Mm-hmm.
I think I lost my track of thought. Go ahead, Carrie.
You said you were talking about housing shortages in San Francisco and things are being expensive.
Well, finding housing that is, elder accessible, elder friendly. I live 2 blocks from a big LGBT aging housing center, brand new, really nice, and it was built a number of years ago. It took 20 years to build it, And the problem is we need housing now, and we need housing that can have bars on this bathtub and in the bathroom to get safely around. I can't tell you how many numbers of falls I have made going to the bathroom in the middle of the night in my studio apartment. And it's scary because falls are not something you want to do a lot because you can't recover from them if you're not careful. So the frailty issues really need to be addressed and how we think about moving forward with housing. Frailty and the sense of, if you live alone especially, it's really hard to do everything you need to do for yourself. So we have to have assisted living is what we have to come up with. We don't have it. We just don't have it so much at this point. Any more than the heterosexuals and the rest of the world have it. People who are not HIV positive have it either. We don't have it. It's something we've all overlooked.
Yeah, and I know that when the HIV and aging primer was written, and you guys supported that in the last round, there are some sections on some of that advocacy that we need, so because from a policy perspective, we have a lot of advocacy around aging, But when we talk about people who live in major cities, major metropolitan areas, especially cities like San Francisco, cities like New York, which are older cities and those older buildings where there's no elevators and you're walking up, we need organizations to be able to advocate for spaces that are more accessible to people as they get older. And, obviously that includes people living with HIV. So one last question in this section: what other barriers do older adults with HIV specifically face when accessing healthcare? What other barriers do older adults living with HIV face when accessing healthcare? Akshay, I'll let you jump in on that first.
Accessing healthcare, the barrier will be transportation, getting to your doctor appointments. It also, you have folks who have dementia, and remembering to take the medications that they need to take. I know right now I'm dealing with high blood pressure as well as diabetes. Um, I am undetectable, so I'm not worried about, my HIV status. But however, as I age, I know that dementia is in my family history, high blood pressure, and just maintaining that, and as eating healthy, making sure that I exercise. And I know that there is a lack of resources as far as housing, like Carrie has mentioned, not Carrie, but Taz had mentioned earlier. That is just for the transgender individuals, especially trans men, because there might be facilities for trans women, but there aren't that many facilities for trans men. So that's a barrier that trans men will face, not being able to have the access to assisted living. And now we have to worry about um, our social security getting depleted. We might not have access to our social security with the Dodge program that's going on now, because they want to have access to everything. So it's very scary for the trans community. And we just need that support, and we need our allies to be there for us like we were there for y'all. Now it's time for y'all to return the favor and be there for the transgender community, trans men as well as trans women, non-binary, everybody that's in that umbrella. We just need your support and speaking up in places where you might have the privilege to speak up, and for us where we might not be able to. So it's a lot of barriers for the trans community.
I, yeah, I appreciate that. And I want you to expound. I'm going to take a little bit more time. I want you to expound on what the differences in support and advocacy are between trans women and trans men. I've been in a lot of spaces, and I've heard from a lot of trans men who say, there isn't much out there for them. So can you just give me a couple of minutes to talk about, that, so that people who don't know can articulately speak about what you need.
I can't speak from a trans woman experience because I'm not
Mm-hmm.
I'm not a trans woman.
Right. No, I want you to speak from a trans man. What do you need that you're not getting?
However, the spaces that were meant, like MSM spaces, need to invite the trans individuals and trans men in those spaces. And for trans women, the trans women, they have to Black women have to realize that trans women are not a threat to them.
Mm-hmm.
They just want to be recognized as human beings and live their lives. They're not trying to take the place of a trans woman, I mean, of a cisgender woman. They know their place. But however, this is coming from my sisters who have spoken with me. So it's not my story to tell, but however, I'll explain it the best way I can. Black women, there's still, we know there's a difference between trans women and cisgender women, but however, they still identify as women. So therefore, they should be accepted as women because they need the access and the education and the support that the same thing as cisgender women need. Now, for
Right.
trans
Right.
men,
Mm-hmm.
we need, to be accepted in the spaces where we can um be accepted as men, um and there realize there's the difference between sexual orientation and there's a difference between gender identity.
Mm-hmm.
There are trans men who are that consider themselves to be gay.
Mm-hmm.
They identify as a trans man, but however, they have sexual experiences with men, so therefore they are gay. There's a whole, like, I consider myself as a heterosexual man. That's just who I am. That's how I identify. But however, we also have the T for T, where you have trans women and trans men who are in relationships with one another, and those things need to be addressed as well. Like it's piles and piles of things where trans individual need assistance in realizing that, for one, that we could be heterosexual, we could be gay, or we could be bi. Just because we identify as male or female, that's just who we are as a person. But our sexual orientation is who we sleep with. So once
Excellent.
you get past that barrier, I think that the conversations can expand on, okay, now we're here. I see you as a person. I see you need help. You need help with housing. You need help with food. You need help getting you resources to get your access to care and getting your medication. You know, don't leave the trans individuals out of the conversation because we're all human, just like you. We all bleed, and when you open us up, we all bleed the same. We're human. So we're not an experience, a scientific experience, experiment. We are human. Once
Mm-hmm.
we get to that point where we realize, okay, we're all human. We all need access to care. We all need transportation to get to our access to care. We all need shelter. We all need food. Then I feel like we can all have a conversation together. We can all talk together. We can all, be able to combat this political climate that we're in together. There wouldn't be just, okay, we got this army over here, we got this army over there, but we all need the same thing. So why not bring that army together and unite
Excellent.
and fight?
Excellent. Thank you very much. I appreciate that. We are going to move on to the last section of this webinar. I thank you all for your candor and honesty. The future, where are we going? We know that we have right now a political landscape that is trying to, as we said, erase people of trans experience. Hell, they're trying to erase black gay men, black gay women, black folks, period. We ain't they they think that DEI only means black folks, but what that means is they're trying to erase women, period. So we know that the battle is real. So, but specifically speaking of ageism, aging, and living with HIV, how does ageism impact aging with HIV in legal and policy spaces? And I want you guys to really think about the legal and the policy issues that are impacting people living and aging with HIV. Kim, I'm going to start with you.
Okay, I'm on mute. Y'all can hear me?
Mhm.
Okay. So what I want to say, it's I had so much to say. I was thinking of criminalization. I was thinking of just the lack of autonomy. I'm thinking of the lack of specific protections that we would have. And when I think of it's for me in my space, and I'm not going to speak on like a larger space because I can't speak for anybody that's over 50. But what I can think about is remembering how it was. I used to take care of my grandmother and seeing the stuff that I had to do for her and how that parallels with a lot of the things that me and my population are dealing with, where when it comes to trying to be understood, when it comes to just regular screenings that we might not necessarily ask for. And I know it goes into policy because it goes into what our rights are, what is just written out that's already there, that doesn't account for us who's already living with who's younger with HIV or aging with HIV, as Kerry said, since the start, which I really like that framing. We're right now not getting considered of the fact that we are aging with HIV in those spaces. So when we go to the doctor and we know that, for me, I had a stroke 3 years ago. My other friend who is 30, she had a heart attack. I had a couple friends who had dementia, HIV-related dementia. And these are all things that does happen when you are aging with HIV, but there's no proper screenings for that because we don't fit into that category. Even when it comes to cancer screenings, we don't have that until a certain age because we're not even 40 yet. So I think that us advocating for ourselves, having these conversations and advocating to our doctors and really pushing, and it's past the doctors, honestly, because the doctors can do but so much. It's actually going and doing some of the stuff like how we created this primer. Right now we're creating a dual action guide for lifetime survivors so that we can present that not just for the doctors but also for patients, for people like us, so we know what to advocate for. So I think when it comes to policy, it's so broad because policy covers so much that it can hit in any aspect of your life of what needs to change or what we're struggling in.
Thank you. So, as you were speaking, one of the things I thought about was, and I know this was the topic of conversation several years ago, was a patient bill of rights. One of the things that triggered that for me was when you said you were taking care of your mom and you had to advocate for your mom to get, the things that she needed. I too took care of my mom. I was fortunate enough to have a mom who was a nurse. And while my mom had a lot of physical issues, her mental capacity was never faded. And so she was able to have conversations with the doctors about her health care. The that was wonderful for her, and that was wonderful for me taking care of her. However, I often thought about what if my mom didn't know the medical terminology? What if she didn't know, what her body was telling her, and she couldn't articulate that? Because then she just goes into the bucket with the rest of the people and gets her 7 minutes in the doctor's office, and the doctor writes a prescription and says, go on your way. So as you're talking about as we're talking about a policy change, there needs to be something that says, wait a minute, every patient deserves the same equitable care. I know equity is getting to be another bad word, but that's what came to mind as you were speaking.
And Malcolm, I wanted to just add real quick, that also shows the support, because not everybody is fortunate enough to have somebody to be there with them. Right now, we're living in a space. It's still in COVID. How it's not COVID, but we're still in spaces where a lot of people are isolated and have that and don't have that extra help. Tez was just talking about slipping and falling, and I think about, I'm fortunate and blessed that I still have my son here and my husband. That's not the case for most people. So even just with that social isolation, not having that support, and even if you do advocate for yourself, having that extra person there, that representative to help you when you are in these spaces, like a peer navigator to assist you at the doctor's office, to really back that up, because we fall into spaces where they don't want to hear us, not just because of our age, but also because of they already assumed and judged us because of us being positive. So we already discounted at that.
Excellent. Excellent. Thank you so much. I appreciate that. So, next question, what advice do you have for younger advocates supporting older adults living with HIV? I'm going to just open that up to the floor. Anybody can take that. What advice do you have for younger advocates supporting older adults living with HIV?
I think that one of the things that we have to think about is that we are them in the future, and how to treat us like adults and full human beings. I think ageism is such a rampant issue these days. I mean, the grayer my beard gets, the more invisible I get. And I think a lot of it has to do with being seen and heard and given the respect. I mean, I know some people in my life that if I talk about dying or how that looks now, they shut me down really quickly. And it's fascinating because for so long I was prepared to die and I had made all these plans to die. I consider myself an expert on dying, even though I hadn't done it yet. But now there's a kind of switch to not talking about that because they don't want to think about the reality of it. And that's hard because you really want to be able to say, I still have concerns about my old age, whatever that looks like. If it's even imaginable, because for me, for so long it wasn't imaginable, that I still have a hard time grasping being an 80, which a friend of mine just turned 80 here, positive forever. And so it's possible we can live to be that long, 20, 80, 88, 85. But it's hard for me to wrap my brain around. I can't, I don't fully realize what that means, because I feel so decrepit some days that I think, oh my God, this times 20 years is unimaginable.
Do you have any younger people in your life to advocate for you?
I do. And the thing is that a number of years ago, I was working with Sync, the Sync conference, and they asked me to come on and do something for my work. And they went through the list of things, of areas that we're going to do topics on, and aging wasn't one of them. This was early on, back in 2000, I don't know, 2018, 2019. And they said, I went through the list and there was nothing in there about aging. It was all youth. And I said, I'd love to be a help part of this, but I don't see anything here for me because you don't have anything about aging. And so we all politely hung up the phone on our conference call and went our separate ways. And then half an hour later, I got a phone call back from them saying, we've just changed it to generations. We'd like you to lead a conversation between you and two older adults and two younger people. And it was really eye-opening because so many of the things that I thought we had paved the path for, making it easier for people to come out about HIV, come out about sexuality, all the things that I came out of the closet in 1977. So you can imagine what a different world that was. But there was still stigma and all the stuff they talked about, all the things that we had to deal with, they were dealing with too. And it was very eye-opening to see how far we had not come in so many respects, because everyone's got to go through those gauntlets.
Exactly. Yeah. A lot of people are still in that same place They're going through the same things that we went through when we were
The
younger.
journey of coming out, the journey of being open about HIV status and all those things, where you make that decision. I've always been open about my status as I have about my sexuality, because I thought it was important to help other people who might not be as comfortable doing it.
Yep. Who else wants to jump in? What advice? Go ahead. Go ahead,
Just
Action.
as I said, we just think of us as you when you get older. And I will also say learn your history, because when you learn your history, you'll learn that in the 80s, we were dying, and we were thought of as a plague. In the 90s, we were surviving and holding on to a prayer, waiting for a miracle. But now in the 2000s, we are thriving, and the ailments that we deal with is diabetes, high blood pressure, dementia, things like that. And so we just want you to advocate, learn your history, and know that we have been here before. But it's just going to be maybe a little bit tough on getting the results that we need. But just come together and know that we are the older you, because we were here before you, and we just want you to just act accordingly. Just be there. Like we advocated for you, now it's time for you to advocate for us. All this togetherness.
Okay. Anybody else want to jump in?
I do want to add that we haven't talked about trauma about all this, and that's the thing that somebody posted it in the chat group chat. I think we have to address the unaddressed trauma that's going on post HIV. I mean, the world we're living in now is not post; it's present. But the trauma of losing all those friends and people that were close to us and planning to die ourselves, that still resonates. I mean, I think when COVID came around, it was like the epidemic, and I was like, "Oh, they're talking about the epidemic again." And I was like, "Which epidemic? We've lived through one." So we're survivors of two epidemics now, pandemics. But I think the idea is that the trauma needs to be addressed, because I think a lot of us walk around with unaddressed trauma, and it affects everything in our lives: how we behave with the other people, how we behave with ourselves, what we think of ourselves. So I think it's very important for us to not shove trauma work aside, because we have trauma-informed care is very important in this, especially as you age.
Amen. Amen. Trauma-informed care is extremely important. So I've got one last question, and then we're going to turn it over to the audience. There's been a very active chat, and I appreciate everybody's thoughts and feelings that are in the chat. How can intergenerational conversation, so we just talked about younger advocates, how can intergenerational conversations improve the future of HIV advocacy? And I'll let everybody jump in there as well.
So
hold on. Oh, okay. I thought we lost Tez for a minute. Go ahead, Kim.
Oh, no problem. I think it's important. I see that people are opening and trying to have these conversations. And I think I'm going to answer the last question, but also with this question too, because it connects. I think both sides just needs to have patience, right? And be open to hearing the stories. And I'll speak, and again, my generation, I'm young, but I'm young, because I'm not as old as most people on the call. I can honestly say that, or even the demographic that we talk about. But I resonate so much with Tez, because I've been in a space where being told that you should be happy that you're alive, be happy that you made it past the age of 1, that babies were not making it, we were dying, that, as Akin said, that we got to the 20s and we're thriving. I'm still losing my friends. Now, is it as fast as it was before in the early 2000s, in the late 90s? No, because I stopped counting at 50 of the funerals that I was going to. But what I can say is that going to over 50 funerals by the age of 21, and then not having those stories, or the guidance from those who are older, who are experiencing that, did me a disservice. So I feel that it's my job right now to those who are in the 20s, those who are in the late 30s, even the teenagers, the kids that I teach, to pass on these stories of what it looked like, how medication was 25 pills a day, how we were getting, used as guinea pigs on different type of medications, and then hoping that it worked. The coming to the doctor every 3 weeks, every month, getting 25, 30 vials of blood taken away from us. So it's like our stories resonate with those in the early 90s and late 2000s, but we don't have those conversations. So there's that disconnect, that intergenerational talk that we are having pretty much right now shows that we are connected. This is what we're missing. This is what's needed. So that way everybody can see, no, you do understand what I'm going through. So that way we can all fight together. Those storytelling saves lives. I say it to people all the time. And when you know what's going, if I can teach you something on what's going on my part, you can teach me something on your part. I think it's just being able to have patience and listen to each side, and knowing that I don't know everything and you don't know everything, and that we can learn from each other and we can build. So
Excellent. Thank you very much. So anybody else, how can intergenerational conversations improve the future of HIV advocacy?
Yeah, thanks, Malcolm, and definitely thank you, Kim and Tez. Kim put it out there a little bit, and to me, I'm trying to my mind. I problem solve in concepts sometimes, and so when I'm looking at it, it just reminds me of how we used to talk about, or maybe we still do, that the difference in treating HIV and treating the individual. As long as we treat HIV, we have the policy, and where's this funding going to go, and what's the age cutoff for that, and it doesn't put a face to what's really going on. Versus when we treat the patient, when we treat the individual, now that brings in the intergenerational that you're talking about, Malcolm. When we start having the conversation about treating people as people, the rest starts to fall into play. Because I'm optimistic. I'm just optimistic enough that when we start having that face-to-face or that Zoom-to-Zoom conversation with folks, and you understand, wait a second, I had a hard time getting eggs too. I just got my landlord, that they're talking about bouncing too. That's when we start having those conversations where it's no longer we're seeing each other as older or younger or straight and positive and all those things that we tried to label because we're trying to see things as a disease. Let's go back to just talking to people face to face and building our decisions based off of that. I think, Malcolm, I'll give you credit and CHLP credit. This is the start of it. What we're doing right now is how those conversations start. And one of the lessons I've learned from incarceration is that it takes time. It takes an incredible amount of patience. 15 years at the end of the day is a long time.
Mm-hmm.
But it developed in me this sense of recognizing that change is slow, steady progress. Oftentimes, you're not moving at all. Oftentimes it may even feel that I'm not making any progress. But I always remind myself, just as I'm aging with HIV every sunset and sunrise, change is coming every sunset and sunrise. As long as I continue to engage with folks just like we're doing here, as long as I keep swinging my feet out of bed and I keep standing up and I keep not only finding my voice, but encouraging other folks to have their voice as well. That's how we're going to get there. And that's how the overall policy changes will start to become an effect.
Excellent. Excellent. Go ahead, Tess. I saw you come off mute.
Well, I just want to say that one of the things we can all talk about together is self-advocacy. When we go into a physician and thinking of that physician as our partner in our healthcare, I mean, they know a lot, and I depend on mine constantly. But sometimes I have to challenge him and say, "Why are we doing this? Why are you prescribing me more pills? Do we have to? Can we take some away? Because at some point, when you start taking 25 pills, I took that many pills in the early days with HIV because they were trial medications and they were single dose therapies. But now there's blood pressure, there's what's the word I'm looking for? blood pressure and
statins
cholesterol,
and
statins,
cholesterol and
all
statins
those
and all
things.
of that. Yep.
Yeah, and on top of that, I take a couple of antidepressants just for good measure. And it's like a lot of pills in a day. And I live to that already, and my pill box keeps growing and shrinking. Like I go back and I was like, can we combine some of these? Do I have to take this many pills? But asking those questions, knowing that your physician is going to get stuck in a rut and they have a hard time seeing you, you have to sort of poke them and say, hey, I'm here. Listen to me. Don't brush off my answers. If I don't have the answers to the questions I'm asking, that's on me to demand that I have those answers. Things like that, teaching self-advocacy for people.
Yeah, I appreciate that, and I agree 100% because I know, and I'll get right back to you, Carrie. Stuart and I's doctor, he's not really, he's a nurse practitioner, but at one day, Stuart came home and said, Kyle prescribed a different pill for me, and I said, I'm starting to wonder if we're taking too many pills, because at one point I was taking like 5 pills a day, and now I'm up to 10. And okay, and I understand that I need the statin for the cholesterol, and I need this, but I'm really starting to look at, wait a minute, some of this stuff, and starting to ask what is counteracting, what one pill is counteracting the other. So getting that education and self-advocacy is extremely important. So yeah, thank you for that, Tez. Carrie, go ahead.
Yeah, I was going to jump on that same line as Tez, Malcolm. Is that I know that we have a lot of webinars out there, and I've looked at for different opportunities, but to kind of start the process on how to be a self-advocate, because it pulls in so many different areas. And rightfully so. We have, but I'm not trying to add another meeting to everyone's Zoom life. I'm not necessarily saying that, but we don't spend the time on teaching people how to be a self-advocate. Something for me that really helped out years ago was I took a debate class, not because I want to learn because debating is simply self-advocating, and we do it all the time. And so we have folks. And self-advocating is more than just knowing the numbers when we go in to talk to our doctor. Self-advocacy is about being able to be in a space where I'm vulnerable, willing to be vulnerable enough to be seen and to be known, not just to be heard. And how do we encourage people to get to that level? Because it's not easy. I've gone to DOS Point with folks in my own community where they're actually scared to death to walk into the clinic, let alone sit there with the rush and everything that's going on to be able to demand, if you will, that you slow down and you explain something to me. That takes a level of self-awareness, of self-confidence, of of that vulnerability aspect that comes along with living with HIV and aging with HIV. How do we get to that? How do we cross that? And maybe there's a space to start having those type of conversations.
Excellent. All right. So like I said, there's been a very active chat, and I appreciate everybody for contributing there. But before I turn it over to the audience to ask their questions, I want to say thank you guys very, very much. This has been extremely wonderful and helpful, hopefully, to the audience. It's been helpful to me. I've been doing this work for quite some time, and you guys taught me some things. So let's turn it over to the audience for any questions. Any questions in the chat? Dee, are you monitoring questions, or the chat is full. I don't see a question and answer. So is there anything in the chat? Let me look. I've got comments, but I don't see questions. If somebody asked a question, go ahead and repost it. Comment. Encouraging self-advocacy, maybe. Okay. And while we're doing that, I see that Kay Greenberg, and first of all, shout out to Kay Greenberg of CHLP. He is my boss, and shout out to Deirdre Resnick, who is handling the technical part. and Medisa Moore O'Neill, who is the executive director of CHLP. Thank you to the entire team for helping us put on this webinar. We work very closely together trying to, as I say, slay this dragon. We are going to be fighting the system. I think we're all of that age where we remember that song, "Fight the Power." We're gonna be fighting the power for a while. So everybody, put your battle gear on. But some things that came out in this webinar that are very, very important. Some of the barriers that we have are still stigma, even after a certain age. Stigma is still a battle, especially for people of trans experience. But I think one of the keys was, and I think Action mentioned this, education about HIV. I think people living with HIV, have done such a good job in surviving that people think that HIV is gone and HIV is over. And we have to let them know, no, we still take our pills every day, or we get our shot every 2 months, or whatever it is, whatever medication that we're on, but we still have those comorbidities that we're dealing with that are worse because we're living with HIV. And we still have the financial issues and the financial burden. Our medicine isn't cheap. And even if we get any type of assistance, we still have that financial burden. So that's very important. We have to think more and make space for people who are born living with HIV, who are born positive. Aging is not just about you get to that 50-year mark and now all of a sudden you cross over and jump in and say, hey, I'm a person aging with HIV. I see a question in the chat. Do you agree that we need to change our messaging? I need more to answer that question. Avilio, can you say more about that? Pop more in the chat. Do you think we need to change our messaging to do what? And I'll continue while you're typing that in. I also want to put in Tez. You mentioned June 5th, Living Our Legacy, is National Long-Term Survivors Day. So Tez and Let's Kick Ass are a sponsor of that. And so if you're in any metropolitan area where you have people living long-term with HIV, make sure that they are aware that June 5th is Long-Term Survivors Day. And again, going back to what Kim says, for those of you who did not know, dandelions, dandelions are people who were born with HIV. So let's just make sure that we're using the right terminology. And again, we have to be more strategic. We have to be more thoughtful. And I think one of the strategies that we can employ is to start working with people who are fighting the same fight. Tez mentioned the hands-off protest last weekend, and everybody had signs, and nobody was talking about HIV. And that's fine because everybody's mad at this time. But later on, when all of those people get tired of being in the streets, we're still going to be here. And we have to start making sure that we are working with organizations that are advocating for health equity for whatever their constituents are facing. I know that we will be at the On Aging conference on the 21st in Orlando. And that is just about people who are aging and advocating for the rights of aging. And so we need to do more things similar to that, being more strategic. Remember people who have been incarcerated for whatever, for any HIV crime. They have to go on the sex offender registry. And that is a tough uphill battle. It's a tough uphill battle when you've been incarcerated, but going on the sex offender registry takes a lot from you. So we need to start thinking about what that advocacy looks like and how we can help people who have been incarcerated And we also have to start thinking about, and I know that, and I'll shout out Sage. Sage does a good job at this, is helping the people who are getting older and living in spaces that may not be able to accommodate them going forward. You know, whether it be an assisted living space or a full nursing home. You know, gerontologists in nursing homes don't know anything about HIV. So those are some of the things that we have to continue to talk about, and we will continue to talk about those over the next 2 years. We're going to have these webinars regularly. So go to the Center for HIV Law and Policy website and look us up, keep in touch. And I thank you. It's 2:30. Panelists, thank you very much. You guys are fantastic.
Thank you, Malcolm. Good
All
to see
right.
everybody as always.
Thanks, everybody.
Thank you, everybody.
Cam, you're my hero.
Ah,